Hello, everyone, and welcome to the Ramalinga Center's Colloquium on Equity and Social Determinants of Health. Today, we are thrilled to invite Dr. Carolin Elizabeth George to speak with us today about the difficulties of navigating complex medical systems for vulnerable patients. I'll start a little bit with a description of Dr. Carolin. She's an experienced public health expert, and she's currently the head of the Community Health Division, Palliative Care and Research Divisions at the Bangalore Baptist Hospital. This is no small feat. The Community Health Division of the hospital caters to 3.5 million people in low-resource settings in southern India. Dr. Carolin's interests lie in the area of universal access to healthcare and health equity, and her research focuses on the delivery of tailored health service delivery models to vulnerable populations in order to improve population health outcomes. She has ongoing research collaborations with several national and international partners in a range of areas, infectious and chronic disease, epidemiology and surveillance, lifestyle interventions, vaccine immunogenicity, antimicrobial resistance, diagnostic platforms, One Health research, palliative medicine, and more. As an instructor in the areas of family medicine and global health, she molds her undergraduate and postgraduate students to become physicians who serve disadvantaged populations and to become rigorous researchers alongside as well. She has published many papers and serves as a reviewer for multiple international journals. She has many more honors and awards, but it would take too much time to get into here, to list them here, so I will stop for the moment. Dr. Carolin, we are honored to welcome you today to speak as part of our colloquium series. Just a note for the attendees, if you have any questions as they arise even throughout the colloquium, please feel free to put them in the Q&A box at the bottom of your screen, and we will pick them up for discussion at the end of Dr. Carolin's talk. Thank you, Dr. Carolin.
Thank you, Abha. Thank you for the brief description and also one generous words of, I just wanted to thank for this opportunity because, when you called and talked about this thing, it was very heartwarming to know that you wanted to know something which is in real life series, what is happening at the ground level. So my talk would be basically into the realities, what actually we are facing, and also what programs that we have done. So let me share my screen. Is the screen shared?
But you might want to make it full screen.
Yeah. Sure. Yes. I hope the screen is shared and everybody can see the screen.
Yes, it is visible.
Yeah. So let me first talk about India's health reality, at a macro level. Now, at a macro level, there are two things which I wanted to share. One is 60% of India's population earns less than $3.1 a day. That means the median poverty line. That's a huge number. Second fact which I want to point is 63 million are pushed into poverty because of healthcare cost every year. So these two facts are very, very important. First, we are talking about the healthcare access. That is, most people will have very difficulty in accessing healthcare because $3.1 per day, that is around 250 rupees. Second thing what we are talking is, because health is not a luxury, when you need a health intervention, you may have to go and even borrow money. So that is why 63 million are pushed into poverty because of healthcare cost every year. That is around 2 people every second. So this is at the macro level. And at micro level, we asked people, what is a good health system? So we work in different areas. And, for common people, when I asked, what is a good health system? What kind of hospitals that you want? So these are the things that people said. One is good medical team. They should be competent. That means if I have a medical problem, they should be able to give me a solution. Second, be very sensitive. Many times people said that, people are not being, especially the doctors and nurses, are not listening to them or just writing some medications, not even understanding where they're coming from, what their problems are. So people put a lot of emphasis on being sensitive. Second thing they said, it should be relevant. What is available should be meeting the health needs of the people. We should not be traveling very far to get certain services. The other one was available, that when we want, hospital should be open day or night. Everybody talked about pocket friendliness. That is, it should not be very costly. Most people said that 300 to 500 rupees, that should be the bill, which is including everything per day. So when we look at the per capita income, mostly people is around 250 to 300 rupees they're earning per day. So that is why most of them said that, 300 to 500 rupees is something that, people can afford. I spoke about the sensitivity multiple times. Many people said about the sensitivity, that doctors and nurses should listen to our problems, clarify our doubts, do not shout. There are instances where people narrated that when they came to the healthcare provider, the interactions were not very pleasant. There were times in which they forgot medications or did not bring their earlier medical cards. People shouted at them. So when they said about an ideal healthcare system, they talked about being sensitive. The other thing that people said is that there should be dignified delivery of healthcare. If we are unable to pay, this is what they said, if we are unable to pay, there should be provisions to come back and pay the next day or after some time. So this is something which they kept on saying, because there are instances in which when they go to healthcare facility, they really do not know how much money it will cost. Sometimes based on the condition, based on the test, based on the medications, the health cost can vary. And when they are put in a situation where they do not have enough money, and at that point, they do not know what to do, and it is like a compromise of their dignity. So many times they have said this thing, that if we are unable to pay, there should be provisions to come back and pay the next day. So 60% of India's population earn less than $3.1 a day. If you look at most of the hospital, their services are catering to the remaining 40%. That is the affordable proportion. There are vast majority who cannot financially access healthcare. Healthcare is not a luxury. It is essential. Sometimes it is a choice between life and death. So navigating healthcare is tough for everyone, but more so for those who are at the bottom of the pyramid. So in the next few slides, I am going to present about patients' perspective as they navigate through these healthcare systems, but mostly so people who really are at the bottom of the pyramid. Look at Shubha. She is sick. She's a middle-aged lady from one of the villages. Now, when she is sick, she has many thoughts going in her mind. There are many options for her. One is to go to the hospital, or the other is to wait. Do not go to the hospital. Even if she decides to go to the hospital, the other questions are where to go. One is, you have government hospital. In most places, people perceive it as ill-equipped and lack of medical manpower, which are competent. Second, they said about the private hospitals, even in the smaller places, they had private establishments, which they said the doctors are present, they're better infrastructure and more equipped, but they worried about the cost intensivity of those places. They're profit-oriented, and people find it hard to walk into the private hospitals. There were also other options, that some people go to the local healers. Some people went to Ayush doctors. There are instances in which some went even to the veterinary doctors. And also sometimes the doctors become their relatives, or some friends who had a similar illness, and said that you can take this medicines, you will become better. So these are the options in front of Shubha. Now imagine if Shubha is going to the hospital. And what are her concerns? One is alien space, the infrastructure, the different language that is spoken in a clinic. There is loss of autonomy, burden of difficult choices, uncertainty, financial drain, trust issues. I will come to all these points in individual slides. So first coming to the hospital infrastructure. So it's very complex and complicated and most times overwhelming. There are set areas where there are set processes that has to be done in a particular sequence. The most times patient gets lost in this time because the infrastructure, you have to pay somewhere, you have to go navigate to one place. Once you pay certain places, you have to wait for certain areas. Doctors, some people will call your name, some places it is silent. So there are innumerable processes that happen in the hospitals. This is, for most people, it's very scary. They get lost. And the conversation also are filled with many jargons where they use medical terminology. If you go to ultrasound, you can go to MRI spaces. So there are certain, so if you're coming from a rural background or are coming from a slum background or from lower middle class, it is very difficult for you to understand this. Sometimes people do not have the language, reading language. So if you do not know how to read or write, that is another problem that people face, because you have to talk to people and to navigate it. It is very, very tough. So that is the hospital infrastructure. There are also people have said, if the hospital infrastructure is very posh, looks like certain hospitals look like um, um, hotels, and in those cases people, especially from the low resource setting, they find it very hard to go there or navigate. Not only navigate, they find that they do not belong to those places, or they are not welcomed in those spaces. So that is about the hospital infrastructure. Then comes the fear, anxiety, and uncertainty. There's a great deal of uncertainty about what is going to happen. So it is coming to a hospital is completely different from going to any other places. For example, if you're going to a mall, you know what is expected. You know which specific places you want to go. You know there is an eatery. So there is a very specified plan, and you know how much money you have got. So how much to spend, how much just to. So there is a certainty for you. But when you're going to healthcare spaces, there are a lot of uncertainties. One is it going to be a serious problem? Am I harboring something? Is the doctor going to look at me and say that I have cancer or I have something which is very serious? Am I going to get admitted? So in those cases, many things come to your play. How are you going to, this is a space which is unfamiliar. Second, how are things going to get managed at home? What about children? What about who will stay with me here? What about cow? Or sometimes, many times they talk about their animals and who will take care of them, who will feed them, all those things. Then there's a lot of anxiety about different tests that is going to get performed. Is it painful? Can anybody accompany me to those places? Sometimes they also talk about you may have to remove certain, expose yourself and have to go to certain spaces like MRI and ultrasound. In certain spaces, when they go, people feel very anxious where you have to go alone. And sometimes the previous experiences in the hospital also come to mind. Your experiences from your childhood, it comes to mind, where you were taken to certain spaces, you were forcefully given injections or tests, the pain, all these things comes back to your memories. And so it is not a very pleasant space that people would want to when they think about hospitals. The other thing people talk about is loss of autonomy. Hospital is not a place of comfort, as I said. It's like great deal of powerlessness people feel once they reach the hospital. Some procedures what they have to undergo may be painful, some are embarrassing, some there is a gender issue. You may have to be examined by somebody of the opposite gender. So these are all issues, even though it's not issue per se, but it's culturally people find it difficult to navigate through these spaces. Our choices are limited also. It is very different from buying other services like groceries or garments or something, where we can pick up things based on the resources we have. Here, if the care is vital, we have to buy the services at any cost. There is hardly any choice here. If the doctor says you may have dengue, you may have to get a test done. There is no other choice. Even if you feel there is a pain associated with a prick taking blood, if you're scared of that, or the cost is 350 rupees or 450 rupees, whether you want it or not, you would have to do it, because that is important for your medical care. So for this, in this space, there is a loss of autonomy, where things that is not predicted, things that is somebody else prescribes, you may, whether you like it or not, you may have to go through it. So that is the loss of autonomy. Then comes the complicated space of doctor-patient relationship. Now, this is also a difficult space for people to navigate. Now, traditionally, the relationship is paternalistic. That is, the doctor acts as a guardian. Doctor has the power and decides for the patient. So the patient tells their complaints. After that, the doctor prescribes, these are the tests to be done, these are the medications to be taken. There is not much of discussion between the doctor and the patient, and the doctor assumes the role, saying that I know better. The patient does not have the competence to understand or to give suggestions. Hence, the responsibility of the healthcare or the medical care is solely upon me, and then I take the call. So that is the traditional or earlier conventional one, which is paternalistic. But over the time, it has changed. Now there is mutualistic interactions between the doctor and the patient, where the doctor asks questions, patient says about different options, different problems patient has, and which are the of many problems, which are the ones is more distressing and which the patient wants to get treated for. So there is an element of exchange between both of them, and in this equation, the doctor and the patient has equal power. In this, even doctor gives different options. In this, you can take the test now, or maybe you can look at your how you are feeling, your temperature chart for 3 days, and if 3 days still, if the patient is feeling feverish, then they can come back and opt for the test. That is one. Or you can today itself take the test. So the doctor offers choices to the patient, and the patient can choose, and both of them are on the same page, and both of them have equal power. Sometimes it can be consumeristic. So this is like, I have given the money, I am sick, I am buying a service, you have to make me well, and that is why I'm paying it. So this is a transactional relationship, and there are relationships like that also between doctor and patient. But I would say in most of the cases, the most beneficial is the mutualistic one. But the expectations of the patient and the doctor may be different. Sometimes the patients want doctor to take the paternalistic role and do not want to decide for them. Whatever doctor says, they want to do it and give complete autonomy to the doctor, and the responsibility and accountability to the doctor. But in some cases, the doctor want to take such a role, but the patient may not be ready to take such a role. The patient wants a mutualistic role, but the doctor is in wanting a paternalistic role. So in those cases in which the expectations of the patient and the expectations of the doctor are different, then there is a great deal of dissatisfaction. And also this is also a complex space where people find it difficult to navigate. We see a lot of patients in different settings, and we have seen that especially women from the lower resource setting, they actually want the doctors to play more of a paternalistic role. It may be due to the conditions they are exposed to at home, where mostly it is somebody takes decisions on their behalf. And then their expectations, when they come to the clinic, their expectations become something like that, that they have to be, the doctors have to take the role of a paternalistic model. Whereas the young people, men, even in the low resource setting, they would want to clarify certain things. They would want to have given options, and they would want to actually take off the different options, choose which is best suited for them. So this is also a common, complicated space, and based on the person's agency, it also makes a person more vulnerable, or make the person, if the doctor is very paternalistic, sometimes it is a very difficult space in some patients, and they find it difficult to ask questions and may not understand certain things and do the follow-up in a wrong way. So these are all problems that we face in this area. This I already explained. Most or the mutuality is the preferred one, and if both the doctor and the patient opens into open communication, their concerns, and doctor refines and give different options and helps the patient choose the best option, that would be the ideal case. So the patients also find difficult when they have to navigate through burden of choices. In most scenarios now, there are many alternatives. So if it is related to taking a test today or taking a test after a week, it's not as complicated. But if it is about different choices regarding treatment options, for example, somebody is diagnosed with an early stage cancer, or somebody is diagnosed with a chronic disease like a diabetes, where already the left leg or some sensations has lost because of neuropathy. The options now you have is multiple, and each option, if you look at it, has a lot of advantages and a lot of disadvantage. For example, a person with cancer, the doctor may say that there is 30% of chance for this to spread over a period of time, so we need to remove it. And one way we can do is we can give first a chemotherapy or a radiotherapy, then after that we can remove the cancer surgically. Or the other option is first we can do surgically remove, after that we can go in for chemotherapy and radiotherapy. After that they will be told about, like, if the choice is A is taken, these are the disadvantages, these are the advantages. And if choice B is taken, these are the advantages, these are the disadvantages. These kind of things can be very burdensome for patients to choose, because there are no clear-cut solutions, and sometimes if they choose wrong, it can cost life. So patients find it, but there is no other choice but to choose. So in the healthcare settings, when especially people from the lower resource setting comes, when they have to choose between alternatives, we have found that they find it very difficult to go through it. Sometimes they say, doctor, you choose, we are unable to choose. or sometimes they have a perception, thinking that maybe the doctor does not know. You may have to go to another person. How can there be options, which is nothing is perfect? Everything has some or the other problems. But wherever they go, they are going to face with the same thing. But even for people who have agency, people who are from the higher affluent groups, they also have these issues, but they are able to navigate through it much better than the people from lower resource settings. There are especially people from affluent societies, they talk to other people who have resources, they read up, they go through the internet, they have other peers who have undergone certain therapies like that, they have second opinion from other doctors. So they have a lot of resources which help them to navigate and say that this choice is better than the other choice. Whereas when it comes to people from lower resource setting, this is a big problem when they have to choose between alternatives. Then comes the trust issues. There is a lack of trust in existing healthcare. Even when we were talking to patients, people know that when they have sickness, they have to come to the hospital if it is not reducing. Most people wait for some time whether the illness can go by itself, but when they feel that it is not possible, they have to come to the hospital. So among the options, even in the government and private hospitals, they find trust as a big problem, because in the government hospital, even though it's pocket friendly, they feel that the doctors, when they go, they are not given proper attention to them. So some people talk about an element of abuse or arrogance in which how the healthcare staff talk to them. So they do not feel that they are valued and they can be they are in a trusted space. But having said that, sometimes that's the only option they have, because government hospitals are pocket friendly. And coming to private hospitals, that's for most people it is aspirational, and they feel that if there is a choice where they have enough money, they should get treatment in the private sector, because they feel the doctors are better, the infrastructure is better, and they have been properly communicated. So they feel that private hospitals are well equipped and can manage their problems better. But there's an element of ethical issues where they feel that whether the healthcare institutions prioritize their revenue over people's health. Always they ask whether, if the test is necessary, whether the admission is done, is it required really or not? So there is a big issue there where people do not trust trust the system which is available for them. The next space or difficult space which people navigate through is financial drain. Usually the consultations are free in government hospitals, but the investigations or medicines in most places are outsourced. So for that, payment is required. It may not be as expensive as the private players, but still it is a private player which is in the government hospital, which is actually shelling out those tests or the medicines, so they have to pay. But in private hospitals, all services have to be paid. In India, the insurance coverage is less than 30% of the population. That means 400 million have no insurance. If they fall sick, they have to, it is all out of pocket expenses. I was just looking at what is the average bill for a patient if they come for any illnesses. So if a patient comes for an illness, it involves a consultation. There will be some lab test, at least 1 or 2 lab tests that is written, and there is medication. So approximately lab tests come around 300 to 500 one test, and there may be mostly two tests, and also the medicines, whatever medicines, again it will come around to 500. So an average bill for an OPD patient comes around 2500 to 2000, and which we said the people have said that what they would like is something which is ranging from to 300 to 500. Now, if the patient has to come for an admission, so I'm talking about the private hospitals. So if you have to have an admission, the admission cost depends at different places at different rates. But if you include the bed charge, the drugs, and the test, even at the general bed, it is coming around 7,000 rupees. Sorry, yes. Yeah, 7,000 to some places is 15,000. Now, in general, what's basically now the 7,000 to 15,000, in some places it is 2,000 is the bed charge. But when you ask people about, when they ask about the drugs and the test, when it is added, it comes around 7,000 per day. And if suppose a person is actually admitted for 10 days, it comes around 70,000. And that is a big amount for most of people. And also some another person will be staying with the person, and there is transport for them, and also the loss of wages. If the patient is admitted in the ICU, again, the cost varies, but even for the basic, if there is oxygen and medicine and the test, the ICU admission cost varies from 30,000 to 50,000 per day. And in a real private setting, even in ventilators and all, it can even rise up to 1 lakh per day. The paying capacity is limited. Most people find it very hard to give liquid cash by when they reach the 2 lakhs. Most of them have sold all the possessions, have borrowed some from their relatives. When it becomes more than 2 lakh, it is they take from the local the bond lenders, and at a higher interest rate, sometimes at very distress, they may even charge 50% of as interest. But these are the people who have resources, who can lead, and at that time, suppose a person requires a immediate a stent or something like that, it is 3 to 3.5 lakh, and they have to, it is a matter of life and death, and then they will go and take loan from whoever is ready to give the money at whatever interest rate. So that is why the initial statistics that we said, that 63 million are pushed into poverty each day because of the catastrophic financial drain expenditure. So when we are talking about when we are talking about the Shubha, the person whom we started with, when she has to think about going to a hospital, her agency is compromised. She feels powerless. There is an alien space. The infrastructure and the language is not very friendly towards her. There's loss of autonomy. There's burden of difficult choices. There's uncertainty. There is financial drain, and there are trust issues. So these are the issues which are very tough to navigate. Now, what if we decide that I don't go to the hospital? Then in your mind, there are these questions. Will I become serious? Will my life be in danger? So when at one point, when the patient finds it difficult to navigate through their day-to-day activities, then they decide to go to the hospital because they find it, they start asking these questions. Is it something serious which I really do not know now? And will my life be in danger? Now, what is the most common scenario? Most times they decide to wait. They do not go to any hospital. Sometimes they go to quacks or to some medical shops and tell what is their problem and try to get some medications. Many reach hospital very late. Often when it becomes very critical, then it becomes very cost intensive, and sometimes we may lose the person too. So uh, yeah, so that's the if I look at the patient's perspective, this is what a normal patient, a person from the low resource setting go through. Now, coming to navigating health system providers and institutions perspective. Now, when we ask people or ask the doctors what should be an ideal treating scenario or a place where you want to work, most doctors want to treat in an optimal way all the patients, irrespective of their financial status. Um, all the options should be equally available, irrespective of the financial status. Infrastructure should be conducive for care, and all needed equipment should be available. So this is the situation that they would like to, and they why they want such situation is that they know that to treat a patient effectively, you have to order tests, you have to have proper history, and you have to, based on the test results, you have to give treatment. Now, for all these things, it requires money. And so the setting should be able to give all these, that is, examination, uh, tests, and medication at a cost where the people can afford. When we asked who should be an ideal patient, they said a person who is invested in health, who is willing to listen to medical advice, who is educated, can easily, who can give a good history, keep track of medical events, who trusts the doctor and follow the advice, and who can pay for the services without much burden. So this is an ideal patient, but most often we do not get even 1 to 2 criteria of this filled. Now, a patient from a poor background or a resource setting comes to the hospital. Even if we want to help them, it's a very resource intensive space. Not only that the test and the medications is expensive, it also, like, for us to make them understand how to fill a form, uh, after doing one particular procedure, where to go, how to navigate through the hospital systems. Even if you tell them many times, people will not be able to understand. People will not be able to understand, or people take wrong routes, and sometimes you may have to navigate through multiple wrong routes finally to get them to the ideal thing. So people, when come from low resource setting, it's quite resource intensive to the existing system, because the existing system is designed for patients who can read and write, who also has the comprehension to look at different systems and find of it's written that I have to go to general medicine consultation. So look at the boards and go to general medicine consultation, pay the cash and wait for your Q turn, and then go and see the doctor. Then, as based on the doctor's instructions, if there is an ultrasound, they should be able to go navigate, find out where the ultrasound is, pay for the services, and based on the doctor's advice, follow the instructions of exposing themselves, or sometimes have to drink water for the bladder to get full. All those instructions they should be able to understand, and they should be able to navigate through it. So it is very resource intensive when it comes to people who do not who come from the low resource setting. Now, if if the hospital is only catering to a low resource setting, then mostly these things are designed to cater to them, and it would be more friendly. But in most cases, especially in cities and in Bangalore, it is not so. So even though the patients that we want are like that, but the realities that we see are different. This is Ali. he plays in a heap of waste. His mother is a housemaid and father is alcoholic. His hygiene is very poor. Now, when Ali becomes sick, he comes to the hospital. So his mother would be accompanying, or his father, who is half drunk, will be accompanying one. Sometimes Ali is accompanied by his older sister, which is only another 2 years older to him. Now, when they come to the hospital, we also have a lot of issues. One is, even his hygiene, his clothing, his ability to understand. None of the tick boxes, none of the criteria that we want as an ideal patient is ticked when Ali comes to a hospital. Now, having said that, Ali requires a hospital if Ali has a severe illness or sometimes a respiratory illness or a diarrhea. If you do not give that medical attention, he may, it can even lead to serious outcomes. So the ideal patient of what we wanted and what Ali is completely different. This is another patient. It's our patient Nagappa. He has a long-standing ulcer in his foot. Now, it requires, he is an agriculture worker or a farmer. He goes and does farming in his field every day. And from that earnings only he lives. Now, actually, because sir, he has to put his feet elevated, has to dress the ulcer every day and keep it clean and neat. But in reality, he does not have the money to dress his wounds every day. Second, if he has to rest his foot, that means he cannot go to his field and work. Then, if he does not do that, he will not have food on his table. This is Manjula. She has a special kid. Now, she lives through the stigma of having a special child. Her husband left her once she had this child. She had to carry the child to reach the nearest auto stand, where she has to take an auto. They will charge at least 500 to 700 rupees. And the rehabilitation services are not there in her vicinity. She has to go at least 15 kilometers, where she has to take the child at least 3 times a week for therapy. Now, she has the responsibility to look after the cot, apart from cooking and washing and doing all other chores in her house. So this is another patient. Patient is her child, but the caregiver, who is Manjula, who is also not coming into the ideal patient, which we have already discussed or which the doctor wants. Next, meet Nagamma. She has terminal cancer. She needs injectable painkillers every 4 hours. She can barely stand. So you can't even think of she going to the hospital for getting the injections every 4 hours. It's an impossible thing. So how will she get her medications? Her pain is excruciating, and even the entire family members, they cannot sleep because she's, sometimes the pain is so bad that she's making, or sometimes she's howling in pain. So these are the patients that we met in real life. So the question is the hospital available mostly in cities or in the peripheries is a match to the real patients and their problems? Probably not. None of the patients that we discussed may not come to a hospital because of financial constraints. Even if they come, the money, time, energy, more of these resources are consumed for them as compared to person from an upper social class. Now, if you look at the provider's perspective, it is true that the patients require medical care and have financial constraints, but hospital is also resource intensive. Theoretically, irrespective of the financial status, people should be given appropriate treatment. But this is not going to be possible on a long-term basis because money is required to maintain the quality of medical services in the hospital. There are no easy solutions for such a thing, on such a situation, but we are able to do our little bit. So, how we are helping people to navigate through complicated medical systems, some real world examples, and how we have helped our patients. Our primary care clinics is located to the most vulnerable communities in the slums, and through the mobile clinics, we actually, and in the villages, pockets, remote rural pockets, we actually go to them. We have a very subsidized rates, like consultation is rupees 10 and 75% of concession, and for the medical test that we give. And if a patient who has a chronic medical condition like a hypertension or a diabetes, the 1 month medication will come around 350 rupees, which most of the people can afford. Why we are giving, I know that this what we are charging, it will not even cover 20% of the expenses that we incur. But why are we still charging? Because free services are not valued. They feel that if you are giving free services, that it's not of good quality. Even if they pay rupees 10, they feel that they are purchasing some services, and they feel that they can ask questions regarding the quality. So there is a social audit that is happening. We have monthly mobile clinics. We go to one place, and exactly after 1 month, we go to the mobile clinics on the same location. This is because we ensure that the care is continued. We also have a home-based palliative care and a hospice which is started for a space if patient has no space at home for end-of-life care. We see almost a lakh of patients in a year through these clinics. These are some photographs where the slums, and you can see the mobile clinic going to the patients, and some home-based or palliative care. These patients have no agency. They cannot come every 4 hours to the hospital to take medication. So we start a subcutaneous line and empower the patient relatives to give every 4th hourly medications through the subcutaneous line. We are available for them throughout the phone, and if they require us to come again, we come. Otherwise, most of the emergency medications based on what is required. Sometimes we know that when we are starting an opioids, they may encounter constipation, or sometimes there may be chance of nausea and vomiting. So based on that, all those medications are given in advance, and over the phone they are helped to administer these medications so that the pain is controlled. Almost in our cases, we have seen that almost 98% of the patients have pain symptoms controlled within 24 hours of our visit. And there is a everybody feel comforted because the patient is not howling with pain. We also create community resource pool. We have trained health workers from the community, and also mothers of the special kids as trained as special educators. This reduces the cost of care, generates local employment and sustainability in the long term. Because even if we are not there, the resources are there in the community. People can interact and they can give the services. And also it helps the people in the community to navigate through the complex medical systems. Our referral is around 5% from the clinics. We give them choices, that is government hospital or the main Baptist hospital. Though government hospitals are exceptional in certain cases like Jayadeva, Nimhans, Kidwai, but there is a long waiting time. So our patients fall through the gap. So many choose Baptist for referral. When the patient reaches the main hospital, we have a chaperone, a patient care coordinator who actually goes with the patient from the starting of registration to discharge. We also help them with concessional charges, very minimal charges. Like sometimes it's like 3,000 for a bill of 1 lakh or 1.5 lakh. So that This is based on the home assessment that we do and recommend based on their affordability. We set aside 17% of our revenue for concession, that is 53 crores in the last financial year from the main hospital, and that is why it is possible. Now, once we have set up all these things, we also looked into what is the social return of investment. So we are putting certain inputs in terms of money, to run these clinics. What is that the outcomes that the community is gaining as health? So we have done thorough calculation, and we have found that if you put 1 million into the rural and urban primary healthcare clinics, then 5.4 million worth of healthcare or health is what the community gains. Also want to give an example of the disability care. Again, when we started in these villages, there was no disability care. People, especially children with disability, were tied to the bed and was so that they don't go to the fireplaces and things like that. We started with a district disability rehabilitation center with the partnership with Government of Karnataka, with technical people, including a limb manufacturing unit and psychologist and the therapist there. After that, we started along with the Anganwadi and the government missionaries that are BSK and government programs. We started screening people, and we used to get 12 to now also get 12 to 20 referrals a week. We go and see whether these children requires evaluation. And if they requires evaluation, we get them evaluated, gets their diagnosis, and finally, we put them into treatment. So in the main center, we give treatment. After that, we have started decentralized small units, which is manned by a mother of a special kid who is trained as a rehabilitation consultant. Weekly, the therapist, that is the specialists, go there and give a chart for each of the child, and looking at that, the mothers of the special kids will give therapy to the children who are coming there. Other than that, there are specialists. So for this program, this is also a very simple program, and we have now made a good landscape for the disability care in rural Bangalore, in Bangalore rural district. And we have again calculated the social return of investment. And when we put $1 million, $13.7 million are the returns. I mean, just to make you understand what SROI means, that is the return the community get as health. I've already spoken about the rural palliative care. Just wanted to say that, we get the calls, and 96% of our scenes within 48 hours and 98% pain control. Even with the complicated cancer care, we are able to give pain control within 98% of the cases. And this is also because we are able to give them morphine and give access to that. We again calculate. Some people have told that end of life care services, if you're doing, there is no return on investment. There is return of investment, because the suffering of the people who are seeing that is too much. And when we calculated it, it has come, the QALYs or the gain by the primary caregiver was 8.1. So I just want to end my talk here, saying that it is a very complicated landscape that people have to go through or navigate if they have to come through come from a low socioeconomic status. Even for people from the affluent societies, it is not easy, but there is a enormous disadvantage for people from lower resource settings. So that is why whatever care landscape that we design, it should value each person, should meet them and their needs, and do it together. That is something we have to be mindful. And everybody can do a little bit. That is something which we believe. So to serve the needy, we should take it as an advantage, as a privilege and an absolute honor. So yeah, thank you.
Thank you, Dr. Carolin. That was the first half of the talk can get a little dispiriting, right? Thinking about all the challenges that one faces. So I really appreciate that you ended it on a more optimistic note. What is the way forward? But that actually brings up a question. I think the Baptist model, and I know there's other,
Yes.
hospitals that have a similar model in other parts of the country too. What does it take to replicate such a model, other than money? This is a question from Professor Srilata, the director of our center.
Human resources.
Yes.
Yes, yes. So human resources, so dedicated professionals. So that's an important question because at least I tell my students, if you can give 2 years of life, you may want to go to corporate setting, you may want to go become more specialist, you may go want to do things. So some people really want to dedicate their life, but everybody doesn't want to be in that setting for longer time. So even if they give their 2 to 3 years of their life to a setting like this, where outreach and primary care is there, that can make a big difference. Second is, it should be rooted in the community. So whatever we are doing, we should always bring resources from the community. It is not easy because their level of understanding, their level of, they also come from the same background, so come with a lot of baggages. But as we work along with them and build them, they become the resource persons over a period of time. So those are the main thing. I see always people as resources.
Yes. No, I think that's a way forward too. Like you said, you have more doctors and nurses, but also sort of building capacity at lower levels as well from people within the community. There
Yes.
has been, alongside your talk, there's been an excellent sort of discussion going on in the chat box that you would not have been able to follow along with. But one part of the discussion has been about the role of publicly funded health insurance schemes. What role has it played in the delivery of healthcare? And what are the challenges as well for people in accessing care, in enrolling for these insurance schemes, as well as accessing care through it? If you could speak a little bit to that.
Yes. So insurance is an important aspect. I think there are central in the publicly funded government insurances as well as private insurance. Now, for common people, what happens is that they do not know when to enroll, how to enroll. So there is most of the population are not enrolling. But even though now there are a lot of organizations, corporates actually trying to empower people and trying to get the insurance done. But the challenges that I face is when most times when they enroll, they really do not know what are their existing health conditions. So what happens is that they may have a diabetic or maybe a hypertension and things like that. And when patient really comes with a disaster, they will say that we have insurance, but this is not being recorded. The history was not given. So what happens? There is a denial happens because they say that it has not been disclosed earlier. Most times that happens because of ignorance. That is one thing. Second thing, even though the insurance are there, the hospitals which are there is enrolled with the insurance sector. They are not in, especially when it's public funded, there are not many. Why this happens? Because there was a lot of earlier time, the government insurance did not pay the hospitals the dues. So when it became more than 2 to 3 crores in each of the hospitals withdrew from those scales. So those schemes. So that is one challenge people, the insurance. So many private hospitals are not there, even though public hospitals are there, but private hospitals are not there. These are the things so one is the number of people enrolled in the, as we said, it's only 30% coverage. So number of people enrolled is less. Of the 30%, most of them are from the affluent. Okay, so there is coverage is less. Second is, even if I have a coverage, I really do not know what are the things that has to be disclosed at the starting of the insurance, because of which my insurance get denied when I want really make use of the insurance. Third thing, what happens is that because of various other non-payment issues and things like that, many of the private providers are not there as part of the And also non-payment, second thing is the insurance, the government insurance charges are very low, which is not a sustainable thing for the private providers. So these are the reasons why insurance is a challenge. But I think going forward, this will become better. Government is looking into those.
Yeah, and like you said, I think the problem such as it is exists at various stages, right? One is the way the program is set up, how people enroll for it, whether what they do and don't know at the time of enrollment, at the time they go to the hospital, as you pointed out earlier in your talk. You enter this overwhelming setting, even if you have insurance, it's still very hard to navigate, even knowing that some of it might be covered, right? So I think that it's a sort of multiple stages at which there are challenges, even if you have health insurance, right?
Yes.
There's more discussion in the chat also about the Indian public health standards and its implementation. And would you like to speak to that as well?
Yeah, okay. That's again, public health standards are very well laid out, but operationalizing, that is the challenge.
I think that is what the discussion is about too, right? So
yes. So again, see, the development has to happen all throughout. When you say that in remote places where there is access to water, access to schooling, access to other amenities are not there, you can't in visualize or even expect that only the health facility will be as per the standards, right? So even though what happens is that people will not come and join there, there is, if anything, so that is also human manpower is a main issue in those areas, because they would have children and other amenities, so the doctors and the nurses would not want to be in those areas. So unless key manpower who want to take charge and to make a change goes to those places, things won't change. Even the standards will only be there on the so what is happening is that very, very deep concentrated development in cities, and there is very, very poor or sparse development in other areas. So that is the challenge. Whereas in areas where there is an almost a good even development like Kerala, the public health infrastructure is much better even for that. So I would say the standards are there. The standards can only become operationalized if there is all other amenities, at least basic amenities come to this thing. Otherwise, we can only talk about it, but it's very difficult to materialize. Abha, you are silent. You're muted.
I'm sorry. Since you said that this is, I mean, there's two sides of it. One is having the infrastructure in place, but the other one is having a trained human resource personnel who can actually utilize that infrastructure in the delivery of care. What more can you suggest in terms of, training health providers? I think in the beginning you brought up, what are the expectations from patients about sensitivity and so on, and what providers say they want to provide but are unable to provide due to a range of reasons. How can we reduce this mismatch? What can we do in the context of like training health providers to provide sensitive care, even in the context of low resources or overwhelming patient loads and so on? What would be, as an instructor yourself, how would you approach this?
Yeah, it is a very challenging question, because the society as such has changed. We have become more transactional, and what you say in terms of what you see, these certain sensitivity is something which you imbibe from your society. That's what I believe. The traffic, when in your normal life, if you are interacting and you're seeing people interacting in a very humane and very considerate manner, you would imbibe as a person. That is one thing. But what I'm seeing nowadays, it's not that. So we have moved from a very empathetic, compassionate species to a very transactional, consumeristic way. So what happens is that when students come to us, it's like, what can I get? There more lot of entitlement. What can I get from the system? How can I become better? That is the most first questions that people ask. But it takes a lot of time to mold them. They have to see us doing in a different way. Take them to the settings where people actually with low resources also, but they are very sharing and genuinely connecting to you. So it takes a while for us to actually take them to settings and live the life, they live what they are supposed to be, that only by those things only that those qualities will come. So it is a challenge. And it's as a society we all have a part to play in this,
Yeah. No, that's a good answer. I think that is, and it's been brought up, I know, multiple times, but once again, the implementation has been the challenging part, right? Post medical education, getting young doctors to spend time in under-resourced areas. Anyway, something to work towards, I suppose. We have a question from Meena Puttaraj, who asks, how do we infuse accountability into our healthcare systems when there's so much opposition from healthcare professionals themselves, the collectives of medical professionals, for any kind of healthcare regulatory reforms in the country?
That is a tough question to ask. Yeah, it's a accountability has been a big issue. I don't know, we always, I really have no answers for this question, because that is, we have a culture of saying passing the buck. It's not, it's, if we are not able to provide, or if you're, we always say that it is that person's or the patient standards have been this thing, or we have not been given the infrastructure, or if so, the accountability, instead of saying that yes, I can make a change and whatever happens, or in terms of I am accountable to it and I work towards making it better. To tell you the truth, that is actually lacking. We always, I don't know, it's a cultural, or we have to look seriously into it. Unless that is changed, it is difficult to actually make a big progress in that area.
I think once again, the answer that you gave for a previous question, which is that, having providers work with underserved, perhaps it'll bring that empathy and that willingness to perhaps put aside these sort of these behavioral traits that seem to be innate to us, to work towards something bigger than that, perhaps, right?
Yes, yes.
Sorry, I'm kind of slipping in the questions between the provider perspective and the patient perspective, but Madhumita asks, how does the referral system play a role in the discontinuation of treatment? I think you ended in your description of Baptist work. We saw how you have sort of very internal referral systems. So you have PHCs and you have other therapeutic and other rehabilitative services all available.
Yeah.
But in a broader sense, how does, can you speak a little bit about the referral system and how that also is a challenge for patients as well, right?
Yes, referral system is a very challenging system. So we are able to do in a small scale where patients are coming to our system where they are registered population and we are looking after them. And when they have an emergency which has to be dealt not in that center but an advanced care, we actually have to coordinate with the main center. Now, if it is actually sent to a government center, we try to talk to the help desk and things, but it doesn't in reality, it does not work. When patient comes there, again, they are falling through the group. Whereas, because we have an internal system, we have a tertiary care system, we tell them to come there, and from there, we have a person assisting them throughout the for the diagnosis to whatever treatment. And if the ICU, most of the the charges are put on credit, and towards the end, because from the hospital concession budget we write it off. And this is also possible that we can actually go a home assessment, because if patients say I do not have money, we really do not know whether it's true or not. There should be an auditing and accountability to the money spending as well. So we have systems in which we can go to the patient's house and do certain evaluation, not in a very interviewing or kind of in getting into their privacy, but basically to understand how much do they have, what do they their family, how many family members are there, what kind of a house, what kind of a setting, do they have loan, do they have, so those kind of systems are built into our system so that we are able to give concessions for the for the really required person, because if without that everybody would say that we would require concession, so that is maybe sometimes overwhelming for any system to handle.
Okay. All right. Thank you. Can you speak? I think that, and this is another question I think that is comes from patient side and the provider perspectives as well, which is the issue of violence in hospitals. Increasingly providers are speaking to how they face violence, and often this is from patients who they perceive do not understand what constraints they are working with or have not understood the medical condition. On the other side, you have vulnerable patients for whom they don't have very many options to sort of speak their opinion or to understand what has happened. Nobody has explained to them. But now there's such a backlash that I think Meena says that it might make him hesitant for patients to speak up as well. So this seems to go back and forth. And how do we resolve this? This seems to be, I think other people have also mentioned that there's this tension between health experts, the providers and so on, and those from the patient community. And how do you resolve that? What kinds of interactions or conversations can help both of these sides understand each other better?
That's a very good question. I would say the first and foremost thing, I would bring the conversation back to trust. Now, if the patient feels that the doctor and the medical team has actually done what is best and trust that what they could do best for the patient, then patients would understand that. That is the basic premise. But what happens when it is not like the earlier time, as I said, our patient doctor patient interactions and the engagements have changed drastically. So it's more of consumeristic, transactional, where one is saying, I have paid money, so I need results. They have not explained properly. They have not, and after paying 5 lakhs or 10 lakhs, the patient died. So there are a lot of, and it may be negligence. It may be, so what happens is that, as you rightly said, both sides can be true. If you look at the patient side, patient is their side is highly vulnerable. They have lost somebody, or somebody is, and they feel that it is because something which the provider has not fulfilled certain expectations. So that is the place that they're looking. What providers feel that we have given everything, we have been explaining, we have given everything, but health, somebody, like, we can give medicines, but the patient will recover or die is not in our hands. At the best, what we can do is we can give the best care and say and hope that the patient comes out. No doctor would want the patient to die. So that is from the provider's angle. But when as a society, when the trust is there, the patients may think they have done unnecessary things because of the money issue, or they may say we were not able to pay on time, that is why the care has this thing, or sometimes in this huge tension, people actually use a certain conversations which was hurting, then it resort to violence. Now, both have, as you rightly said, both have their own way of saying, and it can lead to defensive medicine, saying that I really do, yeah, I really do not want to, like, this is A, B, C, D, you have to do everything. And also I am first itself saying that there's not much of chance of you improving, it's up to you. It's kind of defensive, and write all the investigations so that you cover yourself. Whereas when you want, when there is trust, what you say is, you tell the patient, these are the 5 tests I order first, I will see how it is, and then we'll see, because it's money, right? But you will not get that thing if you are actually, there is no trust. So to bring back the trust as a society, we should again, the consumeristic medicine, the consumeristic and transactional business medicine, considered as a business versus medicine, or the healthcare considered as a vocation, that if people try to start believing that it's a vocation and people are actually living up to that, I feel there would be a change in. Otherwise, it is going to be litigation, it's going to be violence, it's going to be either party not willing to hear other person's perspective, and it is a never resolving issue.
No, I think actually this is a good question, I think perhaps to end this discussion on, because it brings together what we initially thought of this talk as being, you have patient, provider, and institutional perspectives. And I think your response speaks to all of those. There's other comments as well, which we'll share with you later on if you'd like. I think a lot of agreement with what you're saying about immersing medical trainees and young doctors in a range of social and cultural contexts, low resource settings, because that kind of empathy has to, you have to learn to practice in that kind of setting for that empathy to shine in your medical practice down their career as well. So what Baptist does is inspirational, and and what you do is inspirational. So thank you for this. Thank you for this talk. Thank you for sort of giving us an optimistic way forward as well. It's very easy to get, I think, dispirited by the current state of affairs, and so this has been wonderful. Thank you so much, Dr. Carolin. Thank you to all of our attendees for attending and for sharing such beautiful, thought-provoking questions that have given us a good Q&A afterwards as well. We'll see you next at our next colloquium. Thank you, Dr. Carolin.
Thank you very much. It's been an honor. Thank you.